key takeaways from this new sub-analysis is that by week 1 or week 2, we are seeing significant changes in itch and itch control, sleep, and clearance of the skin in our patients. And that is regardless of comorbidities that they may have. And that's from the age 2 and up. A lot of the patients that we are seeing in clinical practice have more than one thing going on in the allergic world. So they'll have atopic dermatitis, allergic rhinitis, and asthma. And what we saw in the sub-analysis was that these patients had the same clinical improvement as patients who only had atopic dermatitis, which is important so that we know that when we are treating all of these patients, that they will see the same sort of results, that their other allergic diseases are not uh, impacting cofactor. So it's really nice.
SORT is simply a safety of oral immune therapy in a randomized trial for milk and peanut. We're comparing 3 different protocol, high dose, low dose, and baked as a different form of allergen. And the study aim actually to look at the safety and efficacy of oral immune therapy, comparing them head to head in 3 different protocols. So the main safety outcome actually was mainly 2. The first one was we did find that having the allergen in a processed or baked form decreased the systemic reaction by 35%. And also at the same time, having higher cumulative doses of the allergen did increase the risk of reaction. So one of the interesting findings that we did find, going with the low dose protocol and with the processed protocol, did achieve the same desensitization rate as the high dose with less side effect profile. And that really challenges the previous belief that you need to go really high to desensitize the immune system.
The key findings of this study was designed as part of the development pathway for Anaphylm in conjunction with discussions with the FDA. So this study was designed in the pediatric age group to bridge, as they call it, to the adult data. So the purpose was not, in contrast to adult studies, there was no comparison with other products, and this was just a single-arm study of Anaphylm administered to children aged 7 to 17 who were 30 kilograms or more, in order to describe the pharmacokinetics, that's the primary endpoint, and to also, as a secondary endpoint, observe the other pharmacokinetic features and the pharmacodynamic activity of Anaphylm in the pediatric age group in children. So the key findings were that the pharmacokinetic profile of Anaphylm in children is basically the same as in adults. So it's a successful study in having shown that we can bridge this product from knowing what we have shown in adults. We can now say that we're finding the same pharmacokinetics in children, and that could allow, without making other comparisons, to bridge, for approval purposes, the analysis of the pediatric use to what we already know about adult use.
They were very positive. Basically, there was a significant improvement in a nasal polyp score from baseline as compared to placebo, nasal congestion score, as well as improvement in Lund Kennedy score that was significant, as well as a big difference in terms of patients who needed a rescue oral corticosteroid or surgery within the time frame of the trial. And there was a significant reduction in the need for oral corticosteroids as well as the need for another surgery. So the exact data is that in the placebo group, about 31% of patients in that group required a oral corticosteroid or surgery versus 3% in the dupilumab group.
So this study showed that the patients in the treatment group, so the ones receiving benralizumab, had a significantly reduced time to first HES flare, significantly reduced flare events overall. And this is really important because flares are a problem with HES. It's a very heterogeneous disease. Patients have a lot of clinical symptoms, and the patients in the benralizumab group really did well, significantly better than the placebo group, with having reduced risk of flares and reduced flare events. There were key secondary endpoints that all had really strong results. So the annualized flare rate was significantly lower. Risk of relapse, so hematologic relapse, for patients who developed an AEC or absolute eosinophil count greater than 1,000, so significantly reduced in the treatment group versus the placebo group. Looked at the PROMIS fatigue score, and that's a fatigue survey that looks at how tired patients are, how fatigued they are, how much it impacts their activities of daily living, and significantly reduced fatigue in the patients that received benralizumab compared to placebo. And that was seen really as early as 4 weeks.